Okay. Well, I think introductions are probably in order. So I'm David Darrow. I'm a pain and functional neurosurgeon at the University of Minnesota. Mike, if you want to go.
Sure. I'm Mike Staudt. I am a pain functional neurosurgeon at University Hospitals Cleveland Medical Center.
And I am Gary Klasser. I'm a professor in the Department of Diagnostic Sciences at Louisiana State University School of Dentistry, and my area of specialty is orofacial pain.
Thank you so much for joining us, Gary. I think I wanted to start just by mentioning that I'm not positive, but I think we have two Canadians in this podcast. Are you? Yeah. So
Go Canucks.
Yeah, Mike is from Canada, and I think you're from Canada as well originally, right?
Correct. Originally, I am from Canada and a place called Winnipeg, which I'm sure you both are well aware of,
Yes.
because when I explain to my American counterparts, first of all, where Canada is, but okay, let's be more specific where Winnipeg is. I say, do you know where Minneapolis is? And they go, yeah. I go, 500 miles north is where I'm from. Mike, where are you from originally?
I'm from just outside Windsor. So when I tell my colleagues where I'm from, I said, you know Detroit, right? It's the neighboring border city.
Okay. And David, you're from?
No, I'm not. I'm not from Minneapolis. I'm from Texas originally and did my schooling in Texas. But I've been here I did my residency here, and I stayed on as faculty. So I've been here for about 12 years.
Okay.
So pretty locked in now with being here at Minnesota. How did you get interested? How did you make your way to orofacial pain? Because it's a little bit circuitous, right?
Oh, yeah, it certainly was. So I graduated from dental school in way back when in 1980 from the University of Manitoba, and I had my own private practice for over 20 years, and I started getting very interested essentially in temporal mandibular disorders, and I really didn't know a whole lot about it, but people started to assume that this person who kind of liked it, they started sending me all these patients, and I literally had to limit my general practice because TMD patients, chronic TMD patients, take a lot of time, and it just, to be honest with you, wasn't very profitable when I could be, filling holes in teeth and doing crowns and root canals and everything else. So I was actually mid-40s, and I said to my wife, would you think, or would you support me? And I had kids in making a major life change, because I really find this interesting. And there's this guy in Kentucky named Okeson, and he seems to be the guru of TMD. And what do you think if, I applied to the program there and we started kind of life over again at mid-40s? And I'm very fortunate. My wife said, I'll support you, whatever you want to do. The kids really had no choice. So she said yes. And I said, look, they're not going to accept me. I'm too old, but it'll be a nice trip. We'll drop the kids off at grandma and granddad's house, and we'll have a fun weekend. We'll look at horses and go to Keeneland and have a fun time. And lo and behold, he accepted me. So I literally in 6 months sold my house, sold my practice, and moved to Kentucky to do graduate work.
Oh, wow.
Then because I was a glutton for punishment, I then did a fellowship in oral oncology and oral medicine at University of Illinois at Chicago. So we lived in Chicago for a while. And then I wanted to pursue a PhD, and my wife said, no, we need to make money because you have a family to feed. So I said, okay. And lo and behold, I was taken on in faculty at UIC. And then a friend of mine who became dean at LSU School of Dentistry said, look, why don't you come down here? And this was kind of post-Katrina. And I kind of remember those images of New Orleans flooding out. I do not live in New Orleans for that particular reason. And I've been here ever since. So that was kind of my circuitous route into academia and orofacial pain. And that's kind of my story. And I don't regret it. I don't look back and say, it was a mistake. I mean, we've really enjoyed a wonderful life as I'm coming to the end of my career soon. But it's been fun.
And one of the reasons that we're talking to you today is because you lead AAOP, right? Which is the biggest orofacial pain association.
So the American Academy of Orofacial Pain is, I would say, the premier organization for orofacial pain. We just became a specialty. The
Right.
American Dental Association recognized finally, after years of trying to become a specialty, became a specialty. It was a bad time. It was March 2020, just at the beginning of COVID. So a lot of the fanfare and trumpeting of us becoming a specialty got put on the back burner because everybody was so concerned, and rightfully so, of what is this new virus that is, destroying a lot of our global population, if you will. But
Right.
we are now considered a specialty, so I can consider myself a specialist. And AAOP is the main organization, evidence-based, very strongly evidence-based, very research-based. So we believe we're the premier organization if anybody is interested in orofacial pain.
Yeah, absolutely. I got to go to the AAOP meeting and give a little bit of a talk when you guys were in Orlando.
Okay.
So few years ago. One thing that's really interesting to Mike and I is, the TMD story and how it interacts with trigeminal neuralgia, which is what we mostly treat. That's really, in some sense, coming about in our field. I don't think it's surprising to you at all, but it'd be awesome to hear from you sort of how that sort of evolved, since, like you said, when you originally were practicing, you didn't know about TMD, and that's sort of the entire field and how it's acknowledged TMD has really changed over that time.
Absolutely. At one time, temporal mandibular disorders, commonly referred to in the lay population as TMJ, and we're trying to educate everybody. TMJ is an anatomic part of the body. It's like saying, I have knee. What you have, if you have some symptoms and dysfunction, is temporal mandibular disorders, which is really a umbrella term for a musculoskeletal disorder. That includes joints, muscles, and associated structures. So it's very, very broad, but it's not per se a diagnosis. In the world of, people think, oh, you're an orofacial pain specialist, so all you deal is with TMD. And if you look at a classification system for orofacial pain, TMD is a very, very small component of what we do in terms of our training, what we manage in terms of professionals, as well as where the research is going. A almost equally large part, or even bigger than TMD, is neuropathic, or I'll say nociplastic pain, which, if we break it into a temporal component, there's episodic, which trigeminal neuralgia really is the poster child. And then another condition, which is not, unfortunately, well recognized by our neurological colleagues, is trigeminal neuropathy. And I think every neurologist, and correct me if I'm wrong, gets very good training on etiology, diagnosis, management of trigeminal neuralgia, but very, very little about trigeminal neuropathy. So in my private practice that I currently have, I often get referrals from neurologists saying, oh, please manage trigeminal or atypical trigeminal neuralgia. Right. And the reason why it's atypical, because that was an incorrect diagnosis.
Right.
It's really a neuropathy. So I think there certainly needs to be much, much better education of the medical field when it comes to neuropathy, because I think they've got neuralgia pretty well nailed down, but neuropathy not so much. In terms of etiology, diagnosis, what do we do? How do we manage? I see a lot of our patients get mismanaged with medications that are used for trigeminal neuralgia that aren't particularly effective when it comes to neuropathy.
Right.
So just interesting. But again, as an orofacial pain person, we break things into Access 1 and Access 2. Access 1 being somatosensory, that's what we see in clinicians we love, but there's that huge psychosocial component associated with it. And, I don't have to tell you, when it comes to chronic pain, it almost really doesn't matter what the cause of the problem was, but you know the driver now is often the psychosocial component to it. And if we start talking about comorbidities and you look at the literature related to any chronic pain condition and comorbidities, the psychosocial component is huge. And we also need to address that. So having behavioral medicine support in everything that we do is paramount in terms of our overall well-being and health of the patients that we are so privileged to manage. Another big thing, you'll never hear me talk about treatment, because treatment implies cure. We're just managing pain. We rarely cure the pain. We often don't even know the etiology. We're unclear of the pathophysiology. So we're managing the pain. And I tell everybody, I'm in the improvement quality of life business. If I can make your life better than what it is, then I'm successful. I didn't say cure your problem, and I really try and drive that home with them. So there's huge overlap between all these various conditions. If you look at a lot of them, they're really on a spectrum.
Right.
And I think we got to, instead of, again, siloing each condition, the overlap is tremendous. And now we're even talking about chronic overlapping, pain. If you look at a Venn diagram, and I'm not a fan of Venn diagrams, but there's a lot of intersection amongst all these various conditions. And it comes back down to they're all related to basically the central nervous system. Right. Something in that part of our hardware is not functioning correctly. It's either dysregulated or dysfunctional, and it has many manifestations. So, yeah, that's kind of the comorbidity in a nutshell.
Those are all such excellent points. I really want to harp on that, or focus on your first one being the neuropathy versus neuralgia. So when I see patients for facial pain, I always tell them, like, facial pain is this. And if you have the diagnosis of neuralgia, you're like this part of it. And I could probably give you the best idea of, as you said, not a cure, but like a potential for pain improvement. But who comes in with neuropathy is actually quite a big segment, I think, that we see as neurosurgeons that are misdiagnosed. You talk about clinicians knowing the difference between neuralgia and neuropathy, or even knowing neuralgia well. I'm not sure that's necessarily my own experience. I would say neuralgia is rarely diagnosed correctly, rarely managed correctly. And we often see people who are delayed many years, like a decade, and finally show up because of either something like a facial pain association advocacy group, ChatGPT, or they've done their own research and they finally said, like, I think I have this. I actually just saw a patient yesterday who was referred from the ER with a diagnosis of occipital neuropathy, and she had giant cell arteritis. So, I think facial pain in general, craniofacial pain, is very poorly diagnosed. And to your point, there's an intersection that we don't often interact with. Hence the purpose of this conversation right here. But we are in our way siloed. So, like, our facial pain that we do at my center, it's me and neurosurgery, neurology, it's interventional pain, but there's also ENT and dentistry on the periphery that we don't interact with that often that we need to. And as we're talking about, we have such a big range of diagnoses that don't often fit into that bucket. And even classical trigeminal neuralgia sometimes has some neuropathic pain components. So how do we treat that, and how do we advise patients on what their successive treatment is? So all excellent points.
Yeah, it's and I think we need to start focusing on two real key things: the integration and the implementation of multidisciplinary and interdisciplinary care, and that's not often done. And we got to start being much more patient-centered and tailor-making the management plan towards the patient's needs, and that includes both physiological as well as psychological and social well-being, because those are huge key factors for somebody's improvement in their, again, overall well-being and just quality of life. And if we stay within our silos and go, no, I'm kind of a mechanical guy and I'm going to take care of your mechanical problem, that's just not going to work. We're treating an entire human being. I always tell my students that tooth happens to be attached to a human being, because in dentistry, we look at almost like a tooth walked into my office and it happens to be attached to a human being. Isn't that interesting? Where, that's just the totally wrong perspective. And again, I know the tooth well, but I don't know the human being well. I would say you got it backwards. You better know the whole human being very well. So it's interesting. We've come a long way. We've got a lot further way of going, but conversations like this, which probably would never even happened 10, 15 years ago, are now happening. So, we're moving slowly. It's a big ship and it takes a while to make that 180-degree turn.
Yeah, there's a lot of parallels, I think, between dentistry and neurosurgery specifically because, you guys operate on a just ginormous number of teeth. And, the vast majority of the time it's fine. It goes well, and every once in a while you end up with someone with neuropathic pain, but you essentially most of the time can cure them of the reason they came in with that tooth, right? You guys do a good job and are skillful at that. In neurosurgery, trigeminal neuralgia, we see a lot of patients with neuropathy, and I think, those of us in the pain side, which is a small part of neurosurgery, are very sensitive to that and have become more sensitive to that. But on the neuralgia side, trigeminal neuralgia side, the mainstay of our treatment is still decompression, microvascular decompression. And, generally speaking, the data is still pretty good for it. It's, pretty high cure rates. 2/3, 3/4 of patients never have to have surgery again or any treatment or anything like that. So it sort of parallels sort of what, I think your percentage is much higher on the dental side, obviously, than ours. But that's primarily because of the, misdiagnosis that I think a lot of us are still trying to figure out, which is one of the reasons why for these guidelines, we did not include anything about diagnosis because we don't feel comfortable being the only one saying something about the level of evidence that's available for diagnosis. And it is really a truly interdisciplinary problem where, we have the international headache and, we have the facial pain and a lot of groups sort of weighing in right now about that. And it's sort of a very evolving target. For good reasons. I think we're heading in the right direction for, being able to do the diagnosis. But I see that, there's a lot of parallels, between what traditional dentistry even does and neurosurgery because of the same sort of issues, which is, do you really understand the whole person? Do you really understand their diagnosis? Because I got to tell you, I have seen some patients present with symptoms that are pathognomonic for trigeminal neuralgia, but I just had a hint that they didn't quite fit the bill. And with traditional conservative care, it got better on its own without medications. And I'm always surprised that someone can have lancinating, shock-like dermatomal pain that's severe, and it can basically eventually be, described as maybe a component of either neuropathic pain or TMD.
Yeah, absolutely. When we're dealing with as you well know, the trigeminal nerve is the largest cranial nerve, and it's the most complex cranial nerve.
Right.
So I always tell my patients, my students, my residents, whoever designed this, whatever belief system you have, must have thought this part of the body, and if you look at the homunculus, you can see 50% of our hard drive, is associated with the hands and the head. So somebody must have thought those parts were very important. We evolved that way. We'll see how we evolve in the future. I won't be here, but somebody will. And in terms of the amount of interplay, convergence with many other cranial nerves, with the cervical nerves, the trigeminal nerve, if it gets irritated, upset, and doesn't like the environment it's in, can manifest in many, many different ways. And I think that's why there is so many, interactions and overlaps of various chronic pain conditions, because when those nerves start acting up, it's anybody's game, basically. It's a very, very complex system that we deal with on a daily basis. And I don't think dentists, I always say if there's one nerve a dentist better know, he better know cranial nerve number 5. And I think they take it for granted. Oh, it's just another nerve, and I go in there and I get the person anesthetized and I do the work and it's pain-free and I'm a good person. And, and most of the treatments are fairly successful because dentistry is very mechanical. It's when it moves out of that very happy paradigm that's when they get confused. And the other major problem, we're trying to change this. In dental education, there's something called CODA, the Commission on Dental Accreditation, and they go around to each school to make sure you're doing everything correctly. Nowhere in their accreditation standards is teaching of trigeminal neuralgia to dental students, which I think is just a travesty, because so many trigeminal neuralgia patients, their first visit, because they think it's odontogenic in nature, because of, it hurts when I brush my teeth or when I touch my face. It's got to be a tooth problem, and dentists aren't even trained to diagnose trigeminal neuralgia. Is just terrible, and
well, that's why
hopefully that'll change with time.
Yeah, I mean, I can't tell you how many patients have shown up in my clinic without any teeth.
Sadly, I have many radiographs of, here's the person when they first presented to the dentist. 6 months later, they're edentulous. And when you look at the initial radiograph, there was no carious lesions or periodontal disease unless they were in a major accident, which most of the time they aren't. What happened? And essentially, the dentist went along, I call it hunting and pecking, and they eventually sent them to me. Now they're edentulous because they literally ran out of things to do. So, now I'm the bearer of the bad news to tell the patient, now you got 2 problems. You still have the problem that you started with, but now you have the problem because we have to rehabilitate you so you can actually masticate food and speak and be aesthetic in a comfortable manner.
If they're not unlucky enough to have both neuropathic pain and neuralgia at that point.
Yeah. And, we all know about central sensitization, and, the neurochemicals are just flying around, and you've got everything involved, and it's those are tough patients to manage. And we usually see them, at least I see them. I'm kind of, as one of my best friends is an endodontist, a root canal specialist. And he says, we get dumped on a lot because if a dentist can't figure it out, it's got to be the pulp. They send him to the endodontist. He views me as, you're the radioactive dump. When nobody else can figure out what things are, then we send them to you. By that time, it's like, okay, what kind of car was I when I'm, been in 5 different motor vehicle accidents? Was I a Mercedes or Chevy? Go figure it out.
Right.
I'm sure you're in the same boat too. You're kind of at the tail end of, well, when people can't figure things out, send them to the neurosurgeon. They can always do something neurosurgically and make the person better.
Yeah, I mean, and that's exactly why, here, I think the thing that we're most proud of is having sort of a comprehensive facial pain clinic that can handle, those patients where in one day we have our, neurologist, headache neurologist, our oral facial pain dentist, the residents, neurosurgeon or 2. We have our nurse practitioner, nurse coordinator, and our pharmacist. And that's the only way. And even sometimes ENT, joins from time to time, depending on the patient. But that's the only way that we're able to make real progress with a lot of these patients.
Yeah. And think of it from the patient's perspective. You've had this problem that's excruciating. It's totally taken over your life, or it has now become your life. You've had it for, 3 to 5 years. You're losing faith in the medical world because every person you go to, whether they do an intervention or not, and, the worst case is when some, medical provider, dental provider looks at them and go, you're just crazy. I mean, you're just, it's all psychological. Think about how they feel. Wow. Not having answers to your problem when you feel it every day is just devastating to your entire overall well-being. So no wonder these people have anxiety and depression and
Right.
all the other psychological issues that are associated with chronic pain when you've basically been pigeonholed. And even, you look at your family starts looking at you rather oddly, like, I tell patients, you would probably rather have a cast in your arm and people will feel sorry for you, than having a trigeminal neuropathy when they look at you and they go, why are you having problems? There's nothing there to see.
Right.
Yeah. So that's why I think we need to also involve more behavioral medicine in what we do. I am certainly not a psychologist. I can't unravel. I call them the onions, and to get to the core takes a long, long time. And if you don't deal with those social or psychological issues, the likelihood of these people ever getting better is not great. I'm sure when, either one of you are doing a, microvascular decompression, to say to somebody, yeah, we're going to kind of like, make a hole in the back of your head. We're going to play around with your brain. There's a lot of vessels there. And, if I slip, this is not going to be a happy story. Wow, facing that is, that's a tough job to do every day.
Interesting point about the cognitive rehabilitation and cognitive approach to that. So in our world, we actually interface with neuropsychology quite a bit. Work up commonly for things like movement disorders, epilepsy. In the pain sphere, it's often for an insurance mandated reason to get a spine stimulator or a neurostimulator for pain. But it's perfunctory. It's a checkbox. Like it's to the patients and sometimes to us, it's almost seen as a little bit useless. I would say in the pain surgery world, we don't have a good approach or even a mandate to approach these disorders like comprehensively with pain psychology or cognitive behavioral therapy. That's a giant blind spot for all of us proceduralists because we just want to operate, we want to treat, and we have our metrics, we have the percentages that we can give patients. But as you said, a lot of these patients we can't cure. We can manage, but who's managing it? It's not us. We're doing the operation. We might do some medical management, but that's like, well, okay, go on and deal with it. So I think that's a really important point and a really big blind spot in how we treat pain.
Yeah, somebody's got to be the quarterback of the team. And, we're really not well trained to be quarterbacks. It's like we do our little bit and, punt, pass it on, to somebody else is difficult. And, a whole other avenue, and I know this isn't what we're here to discuss, is the whole insurance and reimbursement schemata here in the United States. Being a Canadian, being exposed to socialized medicine, that's not I don't believe that's the answer either. But somewhere there's got to be a middle ground, because I guess so many decisions are made not as to what's best for the patient, but it's what's best for their pocketbook, depending upon their insurance company that they're dealing with. And that kind of muddies the water, because insurance companies are not particularly interested in the person's overall health or well-being. They're interested in providing positive results to the shareholders. That's, there's nothing wrong with making a profit, and that's what they're in business for. But man, when it comes to people's health, that's tough.
That's a big problem Dave and I deal with, and anybody who does a lot of facial pain.
I'm sure you do.
Neuralgia, we have our treatments. Everything is covered to a degree. Once you start getting into neuropathy, we know that MBD, percutaneous lesioning, is not going to work. It might make it worse. So what do? We typically do neurostimulation, whether that be trigeminal branch, ganglion, pain pumps, motor cortex. All that stuff is off-label. And so when we talk about off-label, we've been doing it for decades and decades.
Yep.
And I remember when I trained in Canada, we were doing it and had no issue with it. But here, trying to get approval for a trigeminal branch stimulator, putting one electrode supraorbital, is a nightmare. And we fight, and we often lose, and we write letters, and it really sucks. I've had a very bad streak right now. I actually put a craniofacial pain stimulator today, but my past 7 or 8 have been denied, and it's just it sucks because there's nothing else we can really do. And we, again, as proceduralists, want to be able to offer something. So that's not part of this guideline. I think that might be something that comes down the road, because the evidence there is also very not great. It's not rigorous because we don't really have good industry support. Obviously, we don't have insurance coverage, so we can't run large trials. There's been a little bit of more interest recently to kind of develop devices, but it's kind of at its infancy right now. We're still kind of at the whim of insurance just denying us all these treatments.
And the other big thing with TN as well as with neuropathy are diagnoses, and I know you're staying away from the diagnosis, and I understand why. We just don't have markers yet. I mean, it would be great if we had biomarkers. I said, if you want to make life easy, become an infectious disease physician. I mean, you take a swab, put it in the tube, send it to the lab. They tell you what it is. I know what antibiotic I can use, kill the bacteria, done. In our world, it's all taking a history, which is paramount. And again, from dentistry, you don't make money by taking history. You make money by mechanically doing. So history is kind of like, okay. And most of the time in dentistry, it's fairly acute and it's fairly obvious. It's when it gets complex is when things go wrong. So we have often very well-intentioned individuals, but very misguided because they didn't take the time to do the history, and then their clinical exam is only related to odontogenic problems because they don't think outside the box. And that's where patients come in and they're, one quadrant in their mouth is rendered edentulous or has root canals in every tooth, and the person still is in pain. And now the person starts beating themselves up saying, why did I listen to Dr. Klasser who convinced me I needed all these root canals when in fact I didn't? And I kind of sit there and I start doing this little dance like, well, I don't want to throw the practitioner under the bus. I wasn't in his shoes at the time. I do not know. But wow, I guess you must sometimes face that situation is how do you protect a colleague and you weren't there and you're going by patient self-report. So again, you kind of do this little dance without, you're trying to be the diplomat perfecta of trying to, not embarrass the patient, not implicate the practitioner, not saying the system is wrong. Wow, that's a lot of balls in the air to juggle.
Yeah, I think we follow Sir William Osler and try not to disparage our colleagues as much as possible.
Canadian, by the way.
He was Canadian. That's right. He was Canadian. Another Canadian. Gosh. We have one question on our PICOs that's about a little bit about diagnosis, and for us, it really comes down to the notion of visualizing neurovascular compression on patients with idiopathic or classical trigeminal neuralgia, and in that context, the context is that we have a really good history from the patient and everything does line up, but the recommendations for a long time have been you do an MRI to rule out tumor, you do an MRI to rule out MS, and some standard things that we see trigeminal neuralgia emerge from. Because trigeminal neuralgia is not just one. There's not just one etiology for trigeminal neuralgia. I think people sometimes get confused by that. And the second thing is when you're doing MRIs, and they're good quality MRIs, if you just scan 100 people off the street, you will find compression that is asymptomatic, in a lot of patients. And so, for a long time, the MRIs weren't good enough to pick up on that as like an incidental finding. But more recently, because of 7T and some other stuff going on, I've had referrals for patients that don't have facial pain, that have neurovascular compression, and I'm like, this is the wildest incidental finding ever, because I think when it lines up and the patient has clear trigeminal neuralgia symptoms and they have unilateral neurovascular compression or markers of compression, which is like the nerve is pushed to the side and it's in the armpit of the nerve, then it builds a lot of confidence that surgery is a reasonable option for them. because it is, you know, a lot to undergo. But it's not, I think, for a lot of providers, that, you know, a lot of surgeons, that gets lost in the details, and then patients, they're just looking for a diagnosis, and all they care about is the MRI. And I have to tell them, like, look, I believe you. I don't necessarily believe the MRI, and it makes a really complicated discussion because of sort of the misinterpretation of this biomarker.
Are you routinely doing MRAs, or there's no added value to add that other type of imaging to the repertoire?
Yeah, we actually don't, because we developed our own sequences of MRI so that it gives us super clear visualization of both the nerves and the arteries. But the classic teaching from like Kim Burchell is to do both, basically, an MRA and to do a high contrast MRI. We just haven't needed to, because we actually get super clean images of the vessels, and we can do 3D reconstructions that look great. So we haven't had that issue. But I think a lot of places still do both, and they fuse them together.
Okay. And what about MRNs? I know that's still kind of in its infancy. It's not everywhere. They're harder to get.
We do. We even do DTI, which is interesting. But it's only because our imaging center is a pretty big one. You know, between us and WashU, we're the site of the Human Connectome project here in Minnesota. So we have some cool 7 Tesla stuff that we've done. I wouldn't say that we routinely do it, but there are some patients where I suspect that they have actually true neuropathy, and I don't know why. And I'm often looking for, you know, some kind of something along the path of you know, V3 or something like that. And we do some DTI to basically see if we can visualize any, you know, asymmetry between sides.
Okay. But again, I would love if we had some biomarkers that could give us a little more confidence. Certainly, I don't do surgery, but I certainly do a lot of medical management. And you start putting these people on a lot of the medications. I'm very comfortable doing that. And you're adding it to already the medications they're currently on, because none of my patients are ever clean. I mean, they're very complex individual, and that gets very muddy. And again, you know, if you want to start moving to the newer medications that are non-generic, the cost is extreme.
Yep.
You know, so you think, oh, I would really like to try this one. I mean, I just had a patient. I see a lot of patients with burning mouth. You know, I just moved a patient to use some Vertoxetine, and she called me back. She says, I know you really talked, you know, very, very amicably about that, and that would be a good try. But she says, doctor, you know, they want $500 for 30 pills. I'm on a fixed income. I just can't afford that. And it's like, whoa, you know, that's so that's a whole other, from a medical management side, you know, that's also a problem. In terms of management, I know botulinum toxin, which I call it the soup du jour. It's being used to treat damn near everything now.
Yep.
But there are some trials to treat trigeminal neuralgia. Again, are we moving in that direction, or is it still in its infancy? And yeah, let's leave that as a, you know, option for last resort. What is your feeling both on, you know, the use of botulinum toxin? First of all, I always go, where I have not used it for that purpose, and I'm going, where do you inject? I mean,
that's
and how much, and you know.
Yeah. I mean, I don't personally inject it, but we have used it for refractory, so we still use it as a salvage therapy. And you actually you inject it in the distribution of pain with the hope that it gets soaked up into that portion of the ganglion. And so we've seen some really positive results for some patients. But, you know, the thing is like, you know, some patients tolerate Botox really well and some patients don't. And sometimes it lasts and sometimes it doesn't. But definitely we've used it for really refractory patients, especially like patients that they just cannot get surgery for some other reason, you know.
Yeah.
I don't know. You guys use it, Mike?
Our pain group will do it from time to time. It's not common, but again, as you said, for refractory cases, it will be done. They're more inclined to do SPG blocks, especially if there's an autonomic component, more like a TAC. But even for some like just straightforward trigeminal neuralgias to refractory, they'll try an SPG block.
Okay. And when they're doing the SPG blocks, are they doing with a catheter in the nose? Or are they doing it, through the palate or extraorally?
I believe a catheter through the nose.
Okay.
I would have to ask though.
Okay. Because I know there's several systems out there, and
well, there used to be an SPG simulator years ago.
Yeah, now again, from an insurance perspective, I do not know if it's covered, if it's not covered, how many hoops you have to jump through, to get it done. I have no idea about that. So that's always a hurdle, like we mentioned before, you have to go through. Yeah, definitely. So I think the key with all these difficult conditions where we really don't have any objective evidence, to me it's diagnosis.
Mm-hmm.
Are in your training, I guess, let's go back to not your specialized training, but in your medical school training, how much time, two questions, is spent on the diagnosis of trigeminal neuralgia, and how much time is spent learning about the oral environment?
Trigeminal neuralgia, I think we get taught some basics, but dentistry, zilch.
I was going to make a statement earlier when you mentioned that in like dental training, you guys don't have any TN education. We don't get any dental education. You might get one lecture from orofacial surgery, more so due to trauma, but anything else more in depth is nothing. So I mean, again, blind spots on both sides. And so I think it's an interesting point that we're not going after diagnosis for this, but that was actually one of the first things we ruled out in the guidelines, because I think we'd be naive as neurosurgeons to be like, we have the publications and the evidence to make this statement on our own. That might be something that's more appropriate for like a multidisciplinary document. This is more.
Sorry. So with the guidelines, are we mainly looking at surgical procedures, or has there been any, let's look at, medical management before we get to the surgical procedures?
So there's only 8 questions, so I can read you the questions. They're pretty straightforward. So the first question is comparing high resolution MRI versus clinical diagnosis alone. The second question is a comparison of first-line comparisons, which is microvascular decompression versus stereotactic radiosurgery, microvascular decompression versus percutaneous ablative rhizotomy, and then the percutaneous approaches versus each other. So, one question people ask is, do we do a radiofrequency ablation, or do we do a glycerol rhizotomy, or do we do a balloon compression rhizotomy? Those are, and then the last one in this category is percutaneous ablative procedure versus radiation, stereotactic radiosurgery. Then we go into a section that's really focused on salvage therapy. There's 2 questions in this. And the question is, do you repeat the same procedure that you did the first time, or are you switching to a different standard procedure? Is there any evidence for that? And then the 7th PICO is basically what Mike was talking about, which is neuromodulation as a tertiary treatment, and what the evidence is for that. The last question we have is a little bit in that category. It's what we do after treatment. Do we do a structured medication wean, or do we do abrupt discontinuation of medications after treatment? So most of the PICOs are focused on comparative effectiveness, because those are really the questions that patients ask us. What are the trade-offs here? What should I do first line versus second line? What do I do for salvage therapy? Those are the questions that we face, sort of on the the difficult questions that we face. And that's, obviously in reality, as patients go through procedures, I think everybody's questioning diagnoses again. If you don't respond to this, procedure, did we make a mistake on diagnosis? And it's really something else, and I think that's sort of like an ongoing discussion. But I think for the, diagnostic side, obviously it's a much bigger can of worms than just these basic, but we don't even have answers for a lot of these basic questions to,
No,
to tell patients. So it's kind of like we got to have a low bar for our first guideline for trigeminal neuralgia.
Okay. So it's more procedural based, because another key component to trigeminal neuralgia as it relates to dentistry is, I don't think dentists, well, I'm pretty confident dentists are not aware of, if somebody does have active trigeminal neuralgia, and people do need dental work despite having other conditions, is there a fear amongst that person going to the dentist and getting whatever work done? Is that going to remove the genie from the bottle if I've been well controlled, whether it's medically or even if I've had a post neurosurgical procedure? You are playing around with the trigeminal nerve. Clearly that nerve wasn't working all that well. That's why I've been labeled a TN patient. What do I do?
Yeah, that's a fantastic question. And the funny thing is, what we've done here is we have a list of dentists that are okay with seeing trigeminal neuralgia patients. And we hand that list basically to patients because other dentists don't want to see them or freak out, or it's a terrible experience. So we've had to go that route. But you're absolutely right. That's a major issue, especially for patients. They haven't had dental care in 10 years because of what's going on.
Yeah, I mean, because they're just afraid, of any. I mean, when I see a TN patient and they have a episode in my chair, I say, one of the tests I can do is let me go back and stimulate that area that you don't want stimulated because of the overshooting, and they like literally push my hand away. It's like, no way are you touching me in my hot spot, so to speak. I said, no, you've had it, it's okay. And they're like, yeah, right. I've been told that before. So the last thing they want to do is have a dentist, muck around in their mouth when I don't need another episode like that, because it's excruciating. Because again, I can tell you, not only do we not get in our dental training anything about TN, let alone now how do we treat a TN patient when they have TN. And, there are definitely certain things that a dentist could do to lessen the risk, not 100%, but still, and there's no education regarding that. And, somewhere in the guidelines, that would be nice to have, because, again, even if you don't need work, but you're just going in for a recall with the hygienists, they don't even want my teeth scaled by the hygienist, because what if that's the stimulus? And that's the trigger point for another episode.
Yeah.
So what do? I avoid going, and now I've got periodontal disease, and I am forced to go to the dentist because my tooth is waving in the breeze.
Right.
So it's very, very interesting as to what a guidelines could do on many, many different aspects. Obviously, you can't cover everything in the beginning because it would just too onerous of a task.
Yeah.
That's an important point about scope. When we were initially brainstorming topics, themes, we even talked about doing multiple kind of volumes to this. But as Dave said, to be feasible, it's more targeted at this point. But these are all very important, very appropriate questions that could be kind of an extension down the road.
Yeah. Yeah, and I think that's kind of, obviously we'll do a round of the guidelines, and then, the plan is to come back because, we got to revise them and add more stuff on and get, more feedback from you guys and from AHS and all the different groups, because, we're not trying to do this in a silo. It's just, there's only so much time in the day, and we thought that, this would be a good time to talk about the issues what we're talking about today, which is, I think some of us have these conversations within our institution, but interdisciplinary conversations like this between, big organizations that, I haven't really ever seen it.
Yeah, they're relatively rare. AAOP is trying to expand its interactions with multiple organizations. And we think, one of our biggest impediments before this was, again, you're not a specialty. So you're just a bunch of individuals who kind of share this common theme of trying to help people with orofacial pain, but it's not a recognized, shall we say, issue.
Right.
Now that we are, having specialty, we're getting now much more notice from other organizations, from the medical world, as well as other healthcare providers, but also even with insurance companies. Again, you were just a dentist who dabbled in this. No, this is what I do. No, you just dabble, because again, dentists just fix teeth and clean gums. That's basically, all it is. So the other specialty was that was granted was also oral medicine. So they're dealing with a lot of mucosal lesions and things like that. So I'd like to think that the ADA made big strides by accepting 2 additional specialties, because we only have 12 of them. I think medicine, there's 35, 36. I guess they grant specialty, or it's much more lenient process than it is with dentistry. And then you have subspecialties. I always said I want to be a subspecialty premolar dentist. I just want to deal with those, teeth, because it's so simple and easy. But we're not that sophisticated yet. So we're getting there, and we're looking to collaborate both clinically, research-wise, sharing even conferences, and that's why we enjoy inviting people like yourself to a meeting, because it really opens our eyes and vision to whoa, there's a whole other world out there. These aren't really scary people. Maybe we should be communicating with them a whole lot more. And again, the one who's going to benefit, of course, is the patient. We kind of, we're doing this for the patient, but in our minds, we think we're doing it for ourselves and our profession and our field. But again, there's that, patient out there. And I'm a big believer in evidence-based medicine. You go back to David Sackett, and, everybody says, oh, it's all research. I said, no, if you look at the triad, it was research, clinical experience, which gets downplayed a lot, and patients' expectations and values. So it's the triad of all of these that makes evidence-based medicine, dentistry, whatever you want to say. And people often forget about the other two. And, oh, no, you guys are just research guys in the ivory tower, and you like to do, randomized controlled trials and systematic reviews, and, oh, the holy grail, the meta-analysis, and, that's what you base every decision on. I go, no, that's not true evidence-based principles.
Right. We have, we're a small, pain neurosurgery, or pain and functional neurosurgery. We are as subspecialized as it gets, I think, despite the fact that we interact with the most other societies and groups. And we have, I think now more than ever, essentially a voracious appetite for really interacting with, other professional societies, because we recognize how truly interdisciplinary our work is, both, clinically and on the research side, because a lot of us have research programs in trigeminal neuralgia or pain. And so we're extremely excited about, sort of making highways sort of between, a lot of people, at least in this context, who are interested in pain, because we know how important it is to the future. And we are able to move so much faster, as a wider group, because we bring very different perspectives to, the mechanisms and treatment of pain.
Yeah. And it grand rounds involving all disciplines is critical. I mean, David, you're very fortunate. You have a premier orofacial pain program in your backyard. Mike, you probably don't have that. The LSU School of Dentistry, from a geographic, is on its own island. We're half an hour away from the medical people, which makes collaboration very, very difficult.
Yeah.
But knowing how things were in Louisiana, probably some politician owned the land and, got it from the state for a cheap price and made a bundle of money on it. But, be that as it may, if you talk about being in a silo, oh my gosh, we are in a silo here in New Orleans. And I will tell you, I have colleagues who go, why do we even want to interact with those people downtown? it's very comfortable staying in your comfort zone. Nobody likes paradigm shifting. Everybody, wants to grow, but nobody wants to change.
Yeah.
It makes people very uncomfortable, and certainly we got to knock down those barriers and be much more aggressive and interactive in implementing multidisciplinary, interdisciplinary care. And again, the patient is going to benefit ultimately. And that's what we're supposed to be doing this for.
Exactly. Yeah, we really appreciate your time and talking with us about it. Your perspective is invaluable. Exactly what we were looking for. Thank you so much.
Well, thank you. And it is a pleasure meeting both of you. And it's hockey playoff time coming soon in Canada. Are you a hockey fan at all? Pardon me?
Detroit Red Wings fan.
Oh.
Detroit Red Wings fan.
Okay, so I'm a Canadian. Well, I'm a Winnipeg Jet fan, but not this year. But I'm really, before the Jets came in, I'm a Canadians fan. So I live and die by, the Canadians. So it's going to be, it's really going to be a good race right to the end. And Minnesota has a very good team this year.
Yeah.
So it's going to be interesting. Yeah, I'm glued to the TV at this time of year.
But Canadian hockey fans are ever suffering.
Yeah. I know. That was a tough one. And it was a Winnipeg Jet. Hellebuck, he stole the show. I mean, that was, he was just better than the Canadian goalie that day. That really was the difference. But anyhow, be that as it may. Gentlemen, thank you very much. It's been an entertaining evening. If I can help out in any other way, shape, form, just let me know, and hopefully we can break some of those barriers down and be more collaborative in all our efforts.
Excellent.
Thank you so much.
All right. Thank you.